Hello everyone, my name is Preet Jose. I'm a fifth year medical student studying in Charles University Prague, and I'm here today to discuss a few topics regarding leukopenia, leukocytosis, leukemias, and myeloproliferative disorders. I hope everyone finds this helpful. So topics I'll be covering today include, as mentioned before, leukopenia, leukocytosis, leukemias, which include acute and chronic types, as well as the myeloproliferative disorders. The diseases that come under myeloproliferative disorders include CML, or chronic myeloid leukemia, polycythemia vera, essential thrombocythemia, as well as myeloid metaplasia with primary myelofibrosis. And under each of these, I'll be covering the demographic that is commonly affected, as well as basic definition, symptoms, diagnostic methods, as well as the treatment of a patient who is affected by such a disease. Next, you have leukocytosis, which is an abnormal increase in white blood cell count. So this is especially in the cases of it being larger than 11 to 10 raised to 9 cells per liter. These generally leukocytes are of four categories. So you have neutrophils, eosinophils, basophils, as well as your monocytes. And depending on which population is decreased, you can divide them into these four different types. And these are generally manifesting due to their own specific set of reasons, such as in the case of neutrophilic leukocytosis, which is the most common type. You have it increased as a result of a response to infections or hypoxia, or due to inflammatory diseases, due to post-splenectomy states, or due to autoimmune hemolytic anemia, can be due to chronic myeloproliferative disorders, which we will cover in the upcoming slides as well. It can also be due to lymphomas, especially in the case of Hodgkin's lymphoma, or it can be due to exposure to toxins such as snake venom, mercury, And then you have eosinophilia. Eosinophilia is generally occurring in response to allergic reactions, which is its most common cause for increase in number. You can also have it in the case of leukemias, and this can be divided into mild, moderate, or severe. Mild, these numbers are indicative of those three distinctions. So if you have it being less than 1.5, it's considered mild. 1.5 to 5 is considered moderate, whereas more than 5 is considered a severe eosinophilia. Okay, so next you have lymphocytosis. Lymphocytosis is when you have an increase in the amount of lymphocytes. This generally occurs in response to viral infections, and it is considered lymphocytosis when you have levels exceeding 5 into 10 raised to 9 cells per liter. Severe lymphocytosis occurs in the case of malignancy, such as acute lymphoblastic leukemia, or it can be due to EBV, which causes infectious mononucleosis. Pertussis is an important thing to remember here because pertussis is caused by a bacteria which is called Bordetella pertussis, and it's one of the few microbes which are not viruses and instead is a bacteria that leads to an increase in the lymphocyte population. You can also have moderate lymphocytosis where again, viral infections such as EBV or varicella zoster infections, measles, mumps, or CMV infections will cause an increase in lymphocyte number. Monocytosis is when you have an increase in the population of monocytes, or macrophages is these differentiated macrophages which can then hide out in your tissues because macrophages are the few which get into tissues itself. So monocytosis is when you have an increase in population to more than 0.5 into 10 raised to 9 cells per liter. This generally occurs in the case of diseases such as ulcerative colitis or cirrhosis. They can also occur in the case of AML, which is acute myeloid leukemia, which we will cover, specifically of the M4 and M5 variant. And you also have it occurring in the case of infections such as mycobacterial, fungal, or protozoal infections. Okay, now we'll be heading into leukemias. Before we head into that, we're going to talk about the differentiation of hematopoietic stem cells, which is your blood stem cell, and hematopoietic stem cells, which are CD34 positive, will further differentiate into myeloid stem cells or lymphoid stem cells. And these will give rise to their own cell populations. So in the case of myeloid stem cells, you have it differentiating into erythroblasts, which will give rise to red blood cells or erythrocytes. You have megakaryoplasts, which will give rise to platelets. You have myeloblasts. Myeloblasts are the one that give rise to the granulocytes of the white blood cell population. So those will include neutrophils, eosinophils, as well as basophils. And the fourth one, which is not mentioned in this picture, is your monoblasts. Monoblasts will further give rise to monocytes, which we talked about in the case of monocytosis. Next, on the other side, you have your lymphoid stem cells. So lymphoid stem cells will give rise to lymphoblasts, which will give rise to your naive B and T cells. And each of these, depending on the cell population that is affected, give rise to two different kinds of leukemia. So if you have it affecting your myeloid lineage, it'll be known as myeloid leukemia, which can be acute or chronic. And in the case of lymphoid stem cells, it will give rise to lymphoblastic or lymphocytic leukemia, which again, acute or chronic. When you talk about the differences between acute and chronic leukemia, you have two main differences. Acute leukemia, mostly when you look at a blood smear, you will see the presence of a large number of blast cells, which as seen in the picture are basically immature cells. So they'll have a large amount of nucleus as opposed to the amount of cytoplasm which is present in the cell, and this is very characteristic of an acute leukemia. Whereas in the case of chronic leukemia, your mature cells are present. So these are pretty much virtually indistinguishable from your physiologically present lymphocytes or myeloblasts. So they will just be in a very increased number, and they will have some variations in their morphological structure, but in general, your nucleocytoplasmic ratio will pretty much be fulfilled. And moreover, the second difference is that acute leukemia will have a more aggressive clinical course. So the onset, the progression, and the quick worsening of symptoms will all occur in a shorter period of time, as opposed to chronic leukemia, where it's more of an insidious onset and lasts for a longer period of time, with symptoms being not too overtly aggressive. They'll be more generic, non-specific symptoms. So the first category of leukemia, which, like I said, you can divide it into acute or chronic. Acute leukemia is a sudden onset of loss of ability of cell maturation. So you'll have the neoplastic proliferation of blast cells, and a large amount of blast immature cells will be present in the patient's blood. There will be an accumulation of more than 20% blasts in the bone marrow, which is a very characteristic feature of an acute leukemia. Symptoms of these include pancytopenia, so you'll have anemia, which is a decrease in red blood cells. You'll have neutropenia, which will lead to an increase in the risk of getting infections. And you'll also have thrombocytopenia, which will lead to bleeding disorders. And so you'll have less amount of functional cells present inside the patient's blood, but there will be an increase in the white blood cell count, which means your immature cells will be increased in number inside the blood. Normally, your white blood cell count is around 4.5 to 11,000 cells per microliter, whereas in the case of acute leukemia, you will have it being 10 to 100,000 cells per microliter. Moreover, generalized symptoms include generalized lymphadenopathy as well as hepatomegaly and splenomegaly. You can also have, like I said, this affects the bone marrow, which is a major difference between leukemia and lymphoma. So when you have it affecting the bone marrow, it'll cause expansion of the bone marrow and infiltration of the subperiosteum lying above it. And as a result, a patient will typically experience bone pain. And especially in the case of ALL, you'll have it spreading meningally. So this will lead to problems such as headache, vomiting, nausea, blurred vision, nerve palsies, etc. Diagnostics of acute leukemia, you mainly do it through two tests. One is your peripheral blood smear, where you'll see the presence of a large number of immature cells, or you can do a bone marrow biopsy. Bone marrow biopsy is done in order to confirm the diagnosis, because peripheral blood smear is not always indicative, because you won't always have a large proportion of cells present in the periphery depending on when you take the blood, like what stage of the disease you take the blood at. So bone marrow biopsy is used to confirm the diagnosis. So like I said before, you have two lineages that your hematopoietic stem cells differentiate into. You have the myeloid lineage and the lymphoid lineage. So if the cell population being affected is your myeloid lineage, then you can have acute myeloid leukemia, or AML. AML is generally a disease affecting adults around 50 to 60 years, 50s to their 60s, in their 50s to their 60s. A common, very important characteristic of such cells is that they have MPO positivity in their cytoplasm. MPO is myeloperoxidase, which is an enzyme that is present in the neoplastic myeloblasts. So MPO is not present in the case of normal myeloblasts or in cells of the lymphoid lineage. They're only present in the cancerous myeloblasts. And these MPO will aggregates, which will be crystallized, will be found as hour rods on microscopy, which is seen as a picture on the very top. So the arrows pointing to the rod-like structures, those are hour rods, which can be seen on microscopy or through chemical study. And another important feature is that hepatosplenomegaly in AML is less common as compared to ALL, so there will be less dissemination systemically in AML as opposed to ALL. Depending on the cytogenetic abnormalities, the surface markers, as well as the cell lineage, you can differentiate AML into different subtypes. So cell lineage is First, you have cytogenetic abnormalities where you have acute promyelocytic leukemia, which is characterized by a translocation of 15-17 chromosomes, and this is characterized by the presence of a retinoic acid receptor mutation. Retinoic acid receptor is important in allowing for the maturation of your myeloblasts. So it'll allow the cells to become mature and eventually die. And as a result of this being disrupted, you will have the presence of a large number of promyelocytes in the blood, which will lead to a leukemic state. And therefore, a treatment of this kind of leukemia is ATRA, which is all trans-retinoic acid, which binds to the receptor, and therefore that disruption that was initially occurring as a result of the mutation is not present anymore. So the cells, the promyelocytes, will mature and eventually die, and that will therefore relieve the leukemic burden. And you also have an increased risk of DIC, or disseminated intravascular coagulation. This is because in the promyelocytes you have a large number of rods being present, and these rods can activate the coagulation cascade, which will therefore lead to the development of DIC. Second, you have depending on the cell lineage, you can divide it into acute monocytic leukemia and acute megakaryoblast leukemia. Monocytic leukemia is basically what develops from your monoblast lineage, which comes from the myeloid stem cell, myeloblasts. So acute monocytic leukemia, an important feature here which differentiates it from the other kinds of AML is that there is no MPO, or myeloperoxidase, present in the cytoplasm. This generally manifests in the gums, so you'll have an infiltration here which leads to bleeding, which is what is seen in the second picture. Next is acute megakaryoblast leukemia, which again lacks MPO, and as a result, your platelets will not be able to perform oxygen-dependent killing, and as a result, their function is impeded. This is associated with Down syndrome, especially in children that are less than 5 years old. Next is from pre-existing dysplasia. This is the myelodysplastic syndrome, which was mentioned in leukopenia. So basically, myelodysplastic syndrome develops when you have the patient's bone marrow being exposed to harmful irradiation as a result of previous therapy, for example, or it can be due to alkylating agents, like in chemotherapy. So myelodysplastic syndrome is when you'll have a hypercellular bone marrow, but less than 20%, as opposed to AML, which will have more than 20% of it being infiltrated by your cancer cells. So when less than 20% of it is being affected, you'll have a hypercellular bone marrow, and this is what is known as myelodysplastic syndrome. This leads to a cytopenia, which means the number of functional active cells present in the bone marrow, present in the peripheral blood will be less, and as a result, you will have infections because of neutropenia or bleeding because of thrombocytopenia, which is usually what the patient dies from. Or it can transform into AML when your cell population in the bone marrow exceeds 20%. Treatment of a person with AML generally includes two methods. You have either chemotherapy or transplantation. Chemotherapy is done by using drugs such as daunorubicin or cytarabine, which are given in 5 cycles in 1 week blocks, or you can make use of bone marrow transplantation, which can be allogenic or autologous. Allogenic is from a donor, which is HLA matched with the recipient, where first the recipient's bone marrow, the cells are completely irradiated and destroyed, as well as you also make use of drugs like cyclophosphamide, and then the donor's cells are given to the recipient. And when the donor cells are given to the patient, you also give immunosuppressants such as cyclosporine as well as methotrexate in order to decrease the chances of rejection and immune activity against the donor cells. You can also make use of autologous transplantation where the patient's own cells are used. This has advantages including faster recovery as well as less morbidity. Prognosis of a patient with AML is around 10 to 15% 5-year survival rate. Next, you have acute lymphoblastic leukemia, which affects the cells of the lymphoid lineage, which is on the other side. So ALL is more of a disease of childhood, so most affected are children, and it has an association with Down syndrome, especially in kids that are over the age of 5. As opposed to MPO positivity present in the cytoplasm in the case of AML, you have ALL. The cells will contain TDT positivity, so that's your terminal deoxytransferase, which is a DNA polymerase enzyme. So this will be found in the nucleus, and this will be found to be positive in the case of neoplastic cells in the case of ALL. Based on cell surface markers, you can divide ALL into B-ALL, which affects your B cells, and T-ALL affecting T cells. So a way to distinguish this is your surface markers. So surface marker positivity in the case of B-ALL is for CD10, 19, and 20, whereas in the case of T-ALL, it's for CD2 to CD8, anything in between. CD10 is not present in the case of T-ALL. BALL is more common, and based on cytogenetic abnormalities, you can have it being divided into two types. Translocation 1222 is commonly present in the case of children suffering from this disease, and this has a good prognosis as it has a good response to chemotherapy. Whereas in the case of patients with translocation 922, which is the Philadelphia chromosome positivity, this is found in the case of adults, and it is not very responsive to therapy, and as a result has a worse prognosis. BLL in general, however, has a good response to chemotherapy. An important point to note here is that CSF as well as scrotum should be given direct prophylactic administration of chemotherapeutic drugs. This is because the drugs are not able to pass through the blood-brain barrier or the blood-testicle barrier, and as a result, you need to have direct administration to these sites, whereas the rest of them blood will reach through. In the case of TALL, on the other hand, it is more common in teenagers, and it mostly can present as a thymic mass. And as a result of it being present not in the blood, but instead as a solid structure, as a mass, it can be considered a lymphoma. So in the case of TALL present as a thymic mass, it is known as acute lymphoblastic lymphoma. This generally has bone marrow involvement at the time of presentation, so it is considered the leukemic phase. So TALL, teenagers, thymic mass, and it is known as acute lymphoblastic lymphoma in this case. Treatment of ALL includes supportive treatments such as IV fluids and blood, as well as platelet transfusions, because the functional efficient cells present in the patient's blood is quite low, and as a result you give them infusions of this kind, transfusions of this kind. You also give prophylactic antibiotics, antivirals, antifungals in order to prevent the development of opportunistic infections in these patients. You also have chemotherapy against the leukemia itself, which can be divided into 4 categories based on the function that they actually produce in the patient's blood. So you have the induction of remission, which is done by vincristine, prednisolone, as well as L-asparaginase, which is given in combination with daunorubicin. You also have consolidation, where you have the use of high and medium dose therapy over a few weeks. CNS prophylaxis, especially important in the case of ALL because you have meningeal spread to the brain, which leads to headaches, nerve palsies, etc. So you give them intrathecal or high-dose intravenous therapy of methotrexate, as well as make use of CNS irradiation. Maintenance of the therapy is done by making use of drugs like mercaptopurine, which is given daily, methotrexate, which is given weekly, or vincristine and prednisolone, which are in combination given monthly for a period of around 2 years. When these kinds of therapy are not really that effective, or in the case of patients that have a good prognosis or are quite young, in the case of ALL, you make use of bone marrow transplants. Complications that can arise as a result of leukemia, acute leukemias in general, include relapse of the disease, where your treatment doesn't work or you just have it occurring again after period of time. You also have tumor lysis syndrome. Tumor lysis syndrome is basically when you have therapy administered to the patient, such as in the case of chemotherapy, you have massive amount of breakdown of the leukemic cells, which will lead to an increase in the amount of urate being present or uric acid being present inside the patient's blood. This will lead to disorders such as acid-base problems, and as a result, you need to give the patient allopurinol as a prophylactic against urate accumulation. You also have the development of fevers, which is on its own, it's a symptom of AML, and you also have the development of opportunistic infections because of the lack of neutrophils, for example, being present inside the patient's blood. So in particular, you can have diseases such as Candida, PJP, which is pneumocystis cerevisiae, pneumonia, or you can have bacterial septicemia or viral infections such as varicella zoster or cytomegalovirus. You can also have leukostasis. Leukostasis is basically the large amount of white blood cells that are present in peripheral blood, which will lead to an increase in the blood viscosity, therefore leading to problems with circulation of the blood. So that's leukostasis. Next, you have chronic lymphocytic leukemia. Chronic leukemia, as opposed to acute leukemia, like I said before, is composed of mature cells and doesn't have as much of an aggressive course as opposed to acute leukemia. And when you have your lymphoid lineage being affected, it's known as CLL. So CLL is a proliferation of naive B cells, which will show a CD5 and CD20 surface marker positivity. This is the most common kind of leukemia that affects people in the developed world. And in the case of a blood smear taken of a patient with CLL, you'll see the presence of smudge cells, which are what is shown in the picture. They'll basically look like destroyed, stamped out cells, which are remnants of the nucleus that is present. It's more of an artifact of the cell slide preparation as opposed to the actual patient's blood physiology. And this also, you'll have an increase in the amount of lymphocytes being present in the patient's blood. An important characteristic is that CLL can quickly affect the lymph nodes, which will therefore lead to a generalized lymphadenopathy. And in this case, it is known as a small lymphocytic lymphoma. And all that differentiates a CLL from an SLL is that CLL has more of a lymphocyte population in peripheral blood as opposed to a small lymphocytic lymphoma, which is more associated with the lymph nodes themselves. Symptoms of this is very generalized, non-specific symptoms initially. So you'll have symptoms like weight loss, fatigue, anorexia, sweats, etc. You can also have further complications that develop later, including hypogammaglobulinemia. Hypogammaglobulinemia occurs as a result of so basically in CLL, you have a proliferation of naive B cells, so you won't have the maturation of naive B cells to mature plasma cells, and as a result, the amount of antibodies being produced or immunoglobulins being produced by these plasma cells will be very low. And as a result, you'll have a decrease in gamma globulins, which will lead to an increase in the risk of developing infections, particularly by VZV. You also have the development of problems such as autoimmune hemolytic anemia, as well as thrombocytopenia. Another characteristic of CLL is that there is a risk of transformation of CLL to DLBCL or diffuse large B-cell lymphoma, which then this development or transformation to DLBCL is known as Richter syndrome. And you also have the development of generalized lymphadenopathy and hepatosplenomegaly in around 60 to 70% of the cases. A variant of CLL is hairy cell leukemia. Hairy cell leukemia is an uncommon proliferation of mature B cells, which is characterized by the presence of hairy cytoplasmic processes, as seen in the picture. These will be shown to be TRAP positive. TRAP is tartrase-resistant acid phosphatase. tartrate-resistant acid phosphatase, and this TRAP positivity will help you to ID hairy cell leukemia. An important characteristic is that this will give rise to a dry tap as a result of fibrosis of the bone marrow, and you will see massive splenomegaly, particularly affecting the red pulp. Recurrent infections will be present, as well as thrombocytopenia due to a decrease in that cell population, and lymphadenopathy is generally absent in hairy cell leukemia as opposed to CLL in general. This, however, has an excellent prognosis because of the use of 2-CDA. 2-CDA is an inhibitor of adenosine deaminase. Adenosine deaminase is an enzyme that is involved in the purine degradation pathway. So if your adenosine deaminase is inhibited, then you will have the accumulation of toxic products inside the cells, which will lead to the destruction of the leukemic cells, and therefore it is used for therapy. You also have adult T-cell leukemia lymphoma. This is associated with the HDLV1 virus, and it typically involves the CD4 positive T cells as opposed to B cells, which has been the case in the case of CLL or hairy cell leukemia. This is typically characterized by a number of symptoms, including rash, lytic bone lesions, which will be characterized as a result by hypercalcemia. You'll also have the presence of generalized lymphadenopathy and hepatosplenomegaly. Treatment of CLL involves, again, supportive therapy by making use of blood and platelet transfusions, as well as prophylactic antibiotics and antimicrobials, as well as IVIG, which is intravenous immunoglobulins, in order to supplement the hypogammaglobulinemia that is occurring as a result of a lack of maturation. You'll also have chemotherapy, for which you make use of drugs like fludarabine, rituximab, which is a monoclonal antibody, as well as cyclophosphamide. Also make use of corticosteroids, which is effective against the autoimmune hemolysis as well as thrombocytopenia because they will cause an immunosuppression. Radiotherapy is effective against the lymphadenopathy as well as splenomegaly. And you can also make use of stem cell transplantation. Generally, this treatment is administered for CLL in cases of the patients being symptomatic because, like I said, non-specific symptoms generally prevail. And the aim of such therapy is to decrease the severity of the symptoms that develop later, such as your autoimmune problems or lymphadenopathies, etc. And it's to lengthen life and increase the quality of life rather than to completely curatively take care of the disease. Prognosis of this of a patient with CLL is around 10 years. So those were all the leukemias except for CML, which we will cover in myeloproliferative disorders. So myeloproliferative disorders are generally disorders affecting the late adult population, and this is characterized by the presence of a high number of white blood cells present in blood, and you'll have the presence of a hypercellular bone marrow. Generally, in these kinds of disorders, you will have an increase in the cell population of all the cells in the myeloid lineage. So those are your red blood cells, your monocytes, the thrombocytes, as well as the granulocytes. So in the case of myeloproliferative disorders, all of these will be increased, and they're further divided into different types based on the predominance of one particular cell population, such as in the case of polycythemia vera, you will have an increase in all the cell populations. It's just that the red blood cell population will have more of an increase comparatively as compared to the others, but in general they're all elevated. And in these myeloproliferative disorders, you will have the cells being able to terminally differentiate as opposed to leukemias where they lose the ability to mature. Whereas in this, your bone marrow is affected and you will have a hypercellular bone marrow, but the cells are still able to differentiate into the mature forms, and they will show seeding in secondary hematopoietic organs, such as the liver and the spleen, causing hepatomegaly and splenomegaly as a result of the secondary hematopoiesis. Complications in general that arise due to myeloproliferative disorders include hyperuricemia and gout, which arises because of the increased cell turnover, which will lead to development of uric acid accumulation in the blood, which will therefore lead to hyperuricemia and further into gout when it affects the joints. You also have myelofibrosis, which is known as a spent phase, where your bone marrow is not able to produce cells anymore, and hematopoiesis will be completely taken over by the secondary hematopoietic organs. You also have the risk of transformation of these disorders to an acute leukemia. Okay, so the first of the myeloproliferative disorders is CML. CML is a kind of leukemia that falls under this because the lineage being affected is your myeloid lineage. And in this case, you have a neoplastic proliferation of the mature myeloid cells, but especially of the granulocytes. And among these, your basophils will have an increase in number. This generally affects adults, specifically in their 40s to their 60s, and it has a slight male predisposition. Generally, cells that are affected by CML will show the presence of the Philadelphia chromosome. So these are considered Philadelphia chromosome positive or PH positive. And this is when you have a translocation between 9 and 22 chromosomes, and you'll have BCR-ABL fusion. And this will lead to an increase in the tyrosine kinase activity. Tyrosine kinase is a signal transducer that is involved in an increase in cell proliferation. So an increase in expression of tyrosine kinase in the case of CML will lead to an increase in the myeloid cell proliferation. Therefore, treatment of such a disorder is by making use of tyrosine kinase inhibitors, among which imatinib, which is the first generation drug of this kind, is very commonly used. Generally speaking, CML can be divided into three phases. You have the chronic phase, the accelerated phase, and the blast crisis or the transformation phase. So first is the chronic phase, which is characterized, these stages are characterized by the size of the spleen. In the case of the chronic phase, you'll have an enlarged spleen, but it is stable. And in this case, you'll have the presence of either non-specific symptoms such as weight loss, fever, sweats, weakness, etc., or you'll have it more oftenly being asymptomatic. And then you have the accelerated phase. Accelerated phase is called so because you'll have an acceleration of cell proliferation. So you'll have increase in secondary hematopoiesis, but the presence of anemia as well as thrombocytopenia will be commonly observed in these cases because the ones that are produced are not very functional. And as a result, you'll have bleeding disorders, fatigue as a result of anemia, etc. The spleen in this case is enlarging as opposed to it being stably enlarged in the chronic phase. This accelerated phase can transform during the transformation phase to either AML or ALL. That is, it can transform into acute leukemia. AML is more common, around 2/3 of the time it transforms into an AML state, whereas ALL is found in about 1/3 of the cases. And as a result of it being able to transform into both AML and ALL, it is concluded that the mutation is present at the level of the hematopoietic stem cell, which is at the very top, because that is what gives rise to your myeloid and lymphoid lineage. And in the case of transformation, you will see that splenomegaly and dragging feeling as a result of it, etc., will be present. And it's important to differentially diagnose a leukemoid reaction from CML. Leukemoid reaction is when you have an inflammatory response to an infection as a result of which your leukocyte population increases. So 3 parameters can be used. 1, CML will show LAP negativity. LAP is leukocyte alkaline phosphatase, which will be present in secondary neutrophils that are produced in response to an infection. So in the case of CML, LAP will be absent. You also have an increase in basophil population, as mentioned before, as well as Philadelphia chromosome positivity in the granulocytes in CML, which can be seen by means of genetic testing. Treatment of CML, like I said before, involves the use of tyrosine kinase inhibitors. First generation of such inhibitors include imatinib. Second generation drugs such as dasatinib and nilotinib are used in the case of failure of the first generation drug to create a response. So in the case of a blast crisis or the transformation phase where you have it transforming into an acute leukemia, in such cases when imatinib does not not work well, you make use of second generation drugs. These have a more rapid response and therefore can produce better outcomes. Chemotherapy in general is rarely effective against CML, and in the case of tyrosine kinase inhibitors not performing their job, that is, in the case of such therapy failure, you can make use of stem cell transplant. Next, you have polycythemia vera. Polycythemia in general can be divided into primary or secondary. Primary is polycythemia vera, or you have secondary, where you have increased proliferation of red blood cells due to stress environments, such as in the case of hypoxia, or you have it in the case of lung disorders such as COPD. Polycythemia vera, on the other hand, is a neoplastic proliferation of, again, all the myeloid cells, but especially of red blood cells. And this is associated with a JAK2 kinase mutation. This occurs spontaneously during the middle-age adult group and leads to development of hyperviscosity. Hyperviscosity can lead to the development of blurry vision, headache, tinnitus due to congestion of small blood vessels. You can also have congestion leading to a flushed face or the risk of venous thrombosis, particularly of the hepatic veins, which will lead to liver congestion, and that's known as Budd-Chiari syndrome. You also have the development of pruritus due to the release of histamines by mast cells, as well as the development of gastrointestinal symptoms, such as melena, hematemesis, or epistaxis, so due to increased red blood cells. You also have increased cell turnover, which will therefore lead to hyperuricemia, which can present as gout when these uric acid crystals deposit in the joints. And you can also have bone marrow fibrosis, which will lead to secondary compensatory hematopoiesis occurring in the secondary hematopoietic organs, such as the liver and the spleen, which will therefore lead to splenomegaly. Laboratory studies in order to diagnose polycythemia vera will show the presence of increased amounts of red blood cells, as well as an elevation in hematocrit, as well as hemoglobin and peripheral corpuscular volume. You'll also have a decrease in erythropoietin, or EPO, because in polycythemia vera, the proliferation of red blood cells is neoplastic and it is not dependent on EPO levels. Treatment of PV is aimed at decreasing the hematocrit to less than 0.45. So primarily the treatment includes phlebotomy, which is just to remove it, or you have hydroxyurea, which is used in the case of high-risk patients. Alpha interferon is preferred in the case of women of childbearing age. You can also administer aspirin in order to decrease the complications of hyperviscosity. Complications that arise as a result of PV, therefore, will include thrombosis and hemorrhage, again, as a result of the increase in blood viscosity. So you have three primary conditions which you need to distinguish between: polycythemia vera, lung disease, and ectopic EPO. Ectopic EPO is in the case of carcinoma, such as renal cell carcinoma, which will produce erythropoietin themselves from the tumor, so they will have an increase in the amount of erythropoietin. So the first column indicates the oxygen saturation, whereas the second column indicates the erythropoietin levels. In the case of polycythemia vera, the oxygen saturation will be normal because there is no problem with respiration or anything like that. In the case of lung disease, such as COPD, you'll have problems with air respiration, breathing, and as a result your oxygen saturation will be less, whereas in ectopic EPO, again in the case of carcinoma, you'll have the oxygen saturation being normal. Erythropoietin, on the other hand, like previously discussed, will be low in the case of polycythemia vera. In the case of lung disease, it will be high because in response to the oxygen stress in the tissues in the body, you will have the stimulation of production of erythropoietin, and as a result, levels will be high. In the case of ectopic EPO, you will have the tumor itself producing erythropoietin, therefore EPO will be high. The next category of disease that will be mentioned under myeloproliferative disorders is essential thrombocythemia. This was again a neoplastic proliferation of all the myeloid cells, but particularly of megakaryocytes. This typically involves a JAK2 kinase mutation similar to polycythemia vera, but as a result of the dysfunction of platelets, it will lead to an increase in the risk of hemorrhage and thrombosis. There's also the development of microvascular occlusions, which will lead to headaches, atypical chest pains, lightheadedness, etc. There's also a low risk of complications. These complications that I'm talking about are the ones that I mentioned previously in the complications generally that occur in myeloproliferative disorders. So that's transformation into acute leukemias, myelofibrosis, and hyperuricemia and gout. This is because in the case of platelets, the platelets themselves do not have nuclei, and they're instead clumps of cytoplasm forming cells. And as a result of this, you won't have a purine degradation pathway being involved in the breakdown of platelets, and therefore the increased cell turnover won't lead to an increase in uric acid, which means there's a decreased risk of development of gout and hyperuricemia. Treatment of essential thrombocythemia involves the use of aspirin, 75 milligrams, because it acts in order to prevent the development of thrombosis and coagulation problems. You also have the use of hydroxyurea in high-risk patients, similar to polycythemia vera. Next is primary myeloid metaplasia with myelofibrosis. This is basically when you have a neoplastic hyperplasia or proliferation of megakaryocytes. Megakaryocytes themselves will produce transforming growth factor beta as well as platelet-derived growth factor, and these in general act as growth factors which cause the proliferation of fibroblasts in the bone marrow, and it is this increased fibroblast proliferation which leads to myelofibrosis. And this is associated again with the JAK2 kinase mutation. And as a result of the bone marrow not being able to produce blood cells as a result of fibrosis, you will have secondary hematopoiesis occurring to an increased extent, particularly in the liver and the spleen, which will therefore lead to massive enlargement of these organs. Diagnosis of myelofibrosis is done by making use of a leukoerythroblastic smear. So peripheral blood smear will show a characteristic picture, which is known as a leukoerythroblastic smear. That's the picture present on the top. So these basically will be the presence of immature cells. So you'll have the presence of nucleated red cells. Generally, mature red cells do not have nuclei as such being present. So nucleated red cells will be present, as well as your white blood cells, which will be larger than normal. So that's your leukoerythroblastic smear. And you'll also see the presence of teardrop cells, which are red blood cells. That is what's shown in the second picture, and as a result, you'll have a decrease in the amount of hemoglobin. Now, there's a reason for this kind of a picture to develop. Typically, in the case of the bone marrow, you'll have the presence of reticulin gates, which act as a gate in order to prevent the passage of immature cells from the bone marrow to the blood. So these are quite narrow, and as your immature cells are quite large, they're not able to pass through, and therefore only mature cells are present inside the blood. Whereas in the case of myelofibrosis, your bone marrow is not able to produce blood cells anymore. Instead, this function is taken over by your secondary hematopoietic organs. In the liver and the spleen, you don't have the presence of the reticulin gates, and as a result, there is no gatekeeping mechanism that prevents the release of immature cells into the blood. Therefore, you will have the presence of the leukoerythroblastic smear. And in teardrop cells, or the red blood cells that are in this characteristic shape, arise as a result of the red blood cells squeezing through the fibrotic bone marrow, and as a result, these get stretched and therefore form this kind of a picture. Moreover, you'll see the presence of a hypocellular bone marrow with diffuse fibrosis. Symptoms of this disease include weight loss, night sweats, fever, so generalized symptoms. You'll also see the presence of abdominal discomfort, and this is due to the enlarged secondary hematopoietic organs, particularly the spleen, which will therefore lead to discomfort. And the bone marrow failure will therefore lead to a decrease in the cell population, so you'll have cytopenia, which will cause an increase in infections because of decreased granulocytes, as well as an increase in bleeding problems because of thrombocytes being less. You'll also have the presence of high cell turnover, which will therefore lead to the development of gout and hyperuricemia. Treatment of myelofibrosis includes marrow support, and the only treatment available for this case in general is a stem cell transplant. Prognosis of this disease: you'll have a median survival of such a patient being around 4 to 5 years, and typically during this period, the patient frequently suffers from infections, bleeding, thrombosis due to the cytopenias, as well as subcapsular splenic infarctions. These splenic infarctions are typically subcapsular because of the splenic enlargement, so they'll press against the capsule, and as a result of this problem, you will have the development of infarctions. And that's the end of my presentation. I hope you understood everything that I've mentioned so far. I've tried to combine a bunch of resources, but if you have any further questions, let me know. Thank you.